Despite being the leading cause of disability worldwide, many people with depression never receive a proper diagnosis. What keeps this massive illness hidden? Here is the paper itself. Before this seminar, clinicians knew that depression is common, that tools like the PHQ-9 help identify it, and that treatment usually involves antidepressants, therapy, and lifestyle advice. Yet outcomes remain suboptimal, especially in primary care. Malhai and colleagues asked how to close the gap between the high burden of depression and the limited use of effective, evidence-based interventions in everyday practice. The authors performed a comprehensive seminar, reviewing recent systematic reviews, meta-analyses, and guidelines to synthesize practical recommendations for diagnosing and managing adult depression. The team searched major databases for recent meta-analyses and original trials, then graded the quality of evidence and mapped recommendations to clinical pathways. Figure 1 from the paper shows the three-component diagnostic framework. First, elicit depressive symptoms. Second, assess severity and functional impairment. Third, map the episode's course over time. Screening with the PHQ-2, followed by the PHQ-9, provides a rapid yet reliable way to identify patients who need a full diagnostic interview, reducing missed cases. The seminar emphasizes 4 complementary strategies: psychoeducation, lifestyle changes, psychotherapy, and medication, with physical treatments reserved for severe, treatment-resistant cases. Figure 2 illustrates how structured exercise, a Mediterranean-style diet, and good sleep hygiene each contribute to symptom reduction, often comparable to medication. Meta-analyses show that regular aerobic or strength training reduces depressive scores by a clinically meaningful amount, and when paired with psychotherapy, the benefits are amplified. While direct causality is still being explored, observational data consistently associate a Mediterranean dietary pattern with lower depression rates, whereas high intake of processed foods correlates with worse outcomes. Addressing sleep disturbances early, preferably with cognitive behavioral therapy for insomnia, can improve mood and reduce relapse risk. Figure 3 provides a decision tree for choosing antidepressants, taking into account severity, comorbidities, and patient preferences, guiding clinicians toward personalized medication choices. Medication is recommended for moderate or severe depression, especially when non-pharmacologic measures have not achieved remission, and always after discussing risks and benefits with the patient. In practice, start with a quick PHQ-2 screen, add lifestyle counseling and education, and consider antidepressants for those with higher severity or urgent need. The authors acknowledge that their synthesis is limited by the time frame of the literature search, may need tailoring for resource-limited environments, and that some lifestyle evidence is still emerging. Future research should test integrated exercise and psychotherapy protocols, evaluate real-world screening implementation, and explore how diet influences the gut-brain axis in depression. Remember these 3 rules: screen early, use a multimodal treatment plan, and continuously reassess to adapt therapy as needed. A warm thank you to the authors for their comprehensive seminar and to the Lancet for publishing this important work. Apply these evidence-based steps in your practice and help close the gap for millions living with depression.